Here we go. Okay, we're getting there. I can see here now on Facebook. It's a little delayed, but I can see it. It's like watching myself in time, backwards in time. Hello, friends. Can you guys hear me? We're just working on some technical issues.
You could.
I can't see this either. Let me see here. Comments. Something wrong. How about? Here we go. All right, loud and clear, Nancy says. Yes, okay, good.
It's not going to.
All right, perfect. Thank you. Well, welcome everyone to January 2026, a new year of exciting and hopeful things that we're going to be doing. And as always, we're going to be sharing. And so let's just introduce you to the whole studio. This is Eleanor, as you know, my right-hand amazing woman. This is a new member of the family, Margot. Will. This is Margot. She's helping us do all the research. Everyone, unfortunately, knows Will. He's no less hairy than he was last time he was here. And, of course, you all know Kate, who's wearing Imodium-colored scrubs today. That's right. Exactly.
I'm trying to stop the diarrhea.
She's stopping the diarrhea. That's exactly right. All right. Let's get over here. Will has to go do a liver transplant, so he's a very, very busy boy. So we're going to let him go do that. And I'm glad things are working. Okay, let's see here. So I think we've got this whole question thing kind of worked out a little bit. So I'm hoping that we can kind of get through all of them so we can get to your questions and chit chat and talk. Let's see if we can get the first question up. Here we go. Awesome. Ablate or wait? A patient has 3 small liver mets still growing after 3 months of octreotide. Doc stopping the injection. How do you decide to proceed with liver-directed therapy? Wow. So part of I know, right? I mean, these are real questions that we see with real people every single day. So the answer to the question is it depends on how many shots you've gotten. Because if you've only done just 3 or 4 shots, that's probably not enough time to give it to really find out. If there are 3 small tumors, you're actually much, much better off waiting, letting it declare itself, seeing if more tumors come up, and then choosing the right technique. So if they're very, very small, I would actually just let them sit, right? Because they're not life-threatening at all. They're not hurting your liver. There's nothing to worry about. So just leave it be. And then let it declare itself. Because the question is, if you have 3 now, are you going to have 15 in 6 months, right? I'm not saying it's going to happen, but if that does happen, you're going to think of it very differently. And that's it. So for 3 small tumors, I would still stay on the shot because you want to see if it keeps things under control. Or the other option is just to stop the shot and then just see if they grow at all, right? I mean, and do surveillance off the shot because sometimes the shot doesn't work so great. But these are all very kind of generic things I'm saying. So it's hard for me to tell you. You guys have heard me before. Without having the time to study your case and sit here and talk and we all learn and think about it together, it's hard to know. So the problem is there's judgment, there's wisdom, I like to think, and a lot of room for improvement. And look, I'll give you an example. Today we met a patient who lives on the East Coast. And he was basically told he needed to have PRT right away. Otherwise, his head would fall off. That's what the doctors told him. You're going to break your neck and your head is going to fall off. So he bought like a brace for his neck and stuff like that. And the worst part about it is like the treatment that they were offering, which was just Lutathera PRT, would not prevent his head from falling off. So I said, why don't you just hang tight? He didn't have a dotatate scan at diagnosis. He didn't have any of these things. So I said, well, why don't you just wait a second? Let's see how it goes. Your disease burden is very, very small. You feel totally well. We could poison you with your Lutathera. So why don't we see how things go? And that was just a very clear example of how things needed a little bit of wisdom and a little bit of discussion and a little bit of talking. Gloria's on too. I just met with Gloria just the other day, and we kind of chit chat and talk through things too. And that, I mean, hopefully, Gloria, you feel that it was a helpful conversation, because we needed to kind of figure out stuff too. All right, I'm changing my microphone. Let's see if that's any better. Okay. Anyway, so as you all know, I'm not perfect by any means. I never have I ever declared to do that. I declare that I'm funny, and I declare that I'm handsome. Can I say that?
You've said it.
Oh yeah.
You can say whatever you want.
I know, sure. I can say whatever I want. See, now I have a real peanut gallery here. Normally I do this when I'm totally alone, so this is actually getting some feedback. I know, exactly. But if anyone wants to correct them and say anything else, oh, awesome, great news, Sherry. So anyway, so that's the thing. So really the thing is, you need a second opinion. You need to be evaluated. You should get a couple of opinions so you understand what's going on, and I think that's the ideal thing to do. You ready? Next question. Oh, yes. This is pretty cool, actually. Yeah, actually works pretty well. Number 2, does the concept of if we can't remove some percentage of some percentage of cancerous tissue, we will remove the most likely problematic tissue applied to nets? Yeah, I mean, I think there's some truth to that, right? So the way I think about neuroendocrine, as you all know, is it's a marathon, it's not a race, right? And it takes time to figure things out, and you should figure things out initially. And probably most importantly, I want to make sure that your quality of life is as good as possible. So I have had the very unfortunate experience of seeing patients in which if we had done something maybe 2 or 3 or 4 years earlier, they'd be much better off today. And I still recommend getting rid of large tumors because they cause a lot of problems for people. They make them feel bad. They cause pain. They cause bleeding. They cause whatever. I mean, something like really terrible. So I feel very strongly that it's important to think about the most problematic ones. That is true. The issue, the one variable that most people don't understand, is actually the variable of time, and that timing is actually very, very important. So it's not that you have to do anything today, but it doesn't mean you don't have to do something in the future, right? So, like Jason is asking this question, is surgery to remove tumors in the mesentery feasible and possible? The answer is, of course, maybe, right? Because you have to study it. You got to figure it out. You got to figure out where they are. You got to figure out like what shape it is. I mean, the devil's in the details. And the problem is, I'd love to hear you guys comment on this, is that a lot of people who make these decisions for you are not surgeons, or they're surgeons who have no experience doing this, and so they don't know all the tricks and what you can leave, what you can't leave, and what you can remove. Right? Look at Ann Dabbs. Right? I mean, she can tell you that getting her cleaned out is an important thing for her quality of life. Right, Ann? And congratulations to Ann. Ann what'd you get, Ann? Like advocate of the year with NCAN or something like that. I can't remember. Anyway, long overdue recognized award, but you get the idea. And so it is important to always figure out which ones are problematic, which ones are growing, and even if the other ones are not problematic, maybe you can leave them in there and address them in the future. So the answer is yes. All right, next question, ma'am.
You got 10 seconds.
Yeah, here it is. What is the tumor grade of a lung net that was written as having a Ki-67 demonstrating a proliferation index less than 5%? Does that mean I'm grade 1 or grade 2? So in theory, that means you're probably grade 1, right? When it's less than 5%, it just means they didn't count, which means that they think it's super low and it's super quiet. So I don't know, 0, 2, 3, 4, 5, they're all pretty close. The biggest question is it like 10%, or is it 25%, or is it 50%? Like, I'm looking for gigantic changes. The fact that someone chose 2% as a cutoff or 3% as a cutoff is not super helpful, right? Then the other question is, how is it changing? How is it growing? What does it mean? I mean, those are all really the questions that we're asking. Those are the real questions that we're asking. So it's anyone. In fact, we literally just had this discussion just a few minutes ago, right? We were talking about Ki-67s of 30%. And I said, well, okay, if the Ki-67 is 30%, but his disease has been stable for 2 years, then, I mean, what's more important, right? He's still here. Am I going to treat him with chemo because he's been asymptomatic for 2 years and his disease is stable?
No progression.
Right.
Yeah.
Because the most important test is the test of time. Right. So the Ki-67 is essentially what we call a surrogate marker, right? It's something that you can measure right away and may give you a sense of what's going on. But the only test that actually really, it's the test of living, right? Because if you don't die, you're in pretty good shape. I know that sounds ridiculous when I say it that way, but if you don't die, you're doing pretty well. Then the question becomes, okay, well, what does that mean? What is prognosis? Well, then you have to wait and follow scans, and then how are you feeling? Right? I mean, all the things. And it's really about your overall well-being and your health, and how are you enjoying it? Are you right? It's right here, right? Cindy is right here. Cindy Ortel is right here. How well are you sleeping? How well are you eating? How well are you exercising? And how well are you enjoying the time that you have on this earth with the people that you love, right? Those are the important things, and that is really what we need to evaluate and decide. Let's see, Sue says, you mentioned doing enough injections to see if they're working and get enough medicine in your system. How many rounds of injections? Yeah, I can answer that only because it's kind of, so Sue, I would wait at least for 3 to 6. Right. So if the disease is not terrible, it's not like exploding, they grow a tiny, tiny little bit. You don't know if that growth was actually before the shock started or just when it first started. So you don't really know. So if you have a little bit of runway to test it, I would test it. That's what I would do. All right, Margot.
Ready?
Question, lady. What is the surveillance protocol for MEN1 versus other forms of NET? Well, that's actually a really interesting question. So to back up a little bit, MEN1 is what we call multiple endocrine neoplasia 1. It's one version of this mutated gene. And usually what happens is people get a bunch of neuroendocrine tumors in like funky places. They can get in their parathyroids, they can get in their pituitary, and they can get in their pancreas. The parathyroid is the most annoying one by far, and the pancreatic one can sometimes be the most deadly, right? So that's the thing. But deadly is a relative term. Because, don't forget, you've had this disease since you were born. And I can't cure you of it because I can't edit your genes yet. Right. So far, I can't edit your genes. Maybe someday. That's right. Cut and paste. So it is important to kind of think and see how things are. So do you have multiple tumors in your pancreas? Are any of the pancreas tumors growing? Has it spread anyplace else? Has it gone to your lungs or somebody's terrible, or your liver or something like that? So those are the things you've got to figure out. And like how much tumor, how much hormone does it produce? Does it produce a lot of gastrin, so it makes you really sick? The devil is always in the details, and so you have to study these things, figure things out, and go from there. But for the actual surveillance protocol itself is not well defined, because you've got to figure out what it is. So generally what I do, just as a total gestalt, is that I usually scan people initially after diagnosis for about 2 or 3 years, roughly, every 3 to 6 months, depending on how worried I am about them. And I usually alternate the type of scan because you get different kinds of information. Yes, I know you've heard me say before, it's good to compare apples to apples to apples, or oranges to oranges to oranges, except that sometimes if you're going to make a fruit juice, you got to kind of mix it up just a little bit so you get different kinds of information. Thank you. What? None of you people laughed. Come on. Anyway, so what I'll do is I'll get like an MRI to look at the liver. Then I'll get the dotatate scan to look at the whole body. Then we'll switch back to the MRI so we can now compare over this time. And if I'm really worried, I'll compress them into every 3 months. And then as we get a sense, as the test of time goes on, we will expand that depending on what we have to do. But if things are changing, the patient's not feeling well, we have to do something, you have a procedure, all that stuff changes. So if you're purely in surveillance mode, then in short term, you get these scans relatively every 3 to 6 months or so, or whatever, something of that sort, maybe even a year if it's really, really quiet. And then I alternate them like this. and then we expand them as time goes forward. That's basically how it works. Yeah. All right, Miss Margot. You're like a Vanna White. It's like, yeah, you just like turn the screen. Yeah, see, look at her. See, look, she's got that Vanna White look about her, right? Don't you think?
You're running out of time on questions.
No, it's all right. Have you ever, have you ever seen an inverted appendix associated with NET as a primary cancer? Wow, that's really interesting. In general, I've never seen an inverted appendix. I don't really know what it is, but it's not impossible to have as a NET, and I'll explain why. So an appendix is just kind of like the little worm thing that hangs off of the end of your large colon when it first starts, right? Right. They all meet together: small intestine, large intestine, and appendix. But what happens is the appendix is not a it has a function to it, right? It has mucus, it has bacteria, and it has neuroendocrine cells in it. So you can get it. And what happens is if you get a little, so this is not accurate, but if you have a little tumor that's at the end of it and it moves in peristalsis, it can become what's called intussuscepted, which is not quite exactly right, but it inverts. Like the tumor will be pulled and come out, and it'll invert like a balloon, I guess. I'm not sure what would invert in such a way. Almost like a telescope, right? So we get that a fair amount actually with small intestine, but it'll like telescope. So it's not impossible. It's not impossible. I don't think it's any like worse or any different. It just happens to have been a very weird, very, 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 very weird presentation of such a thing. And sometimes it can be a little bit of a pain in the butt to get out, actually. That's really the problem. So if there's any specific thing you want to mention here, we can answer your questions at the end specific to the questions. But it's not impossible. I've never seen it before, but I get it. I totally get it. Yeah. Ma'am, has there been any link between GLP Mounjaro leading to increased tumor growth? Patient has a recommendation to switch from insulin to GLP-1 to reduce A1C. Well, that's interesting. So here's what I can say. So far, and this is just purely observational on my part, I don't know about anybody else, I don't know anything else, but between the people in this room, we have not seen an association between tumor growth and GLP-1s, any of them, whatever the brand is, doesn't make a difference. I cannot say we won't see them. I cannot say that there isn't something. I can't say that someone won't have anything, or I can't tell you that it would have grown anyway with or without the GLP-1s. Right? I can't tell you any of those things. So I don't know. But it is not unreasonable. I'm actually a big fan of insulin. I really think insulin is actually a much better drug for people when it comes to taking care of their diabetes. Yes, I know it's a pain in the butt. Yes, I know it requires injections, but the technology is so good now that I really I prefer insulin, because that's what you're missing. You're missing insulin. You're not making enough insulin. So if you give Mounjaro or whatever the GLP, that's good, because you can, hopefully lose weight, lose fat, not eat as much. It's very, very helpful. It's a wonderful tool to have. But again, you need to think long and hard about how you want to do it, how you want to approach it. Do you want to keep some insulin? Do you want to take it off? I mean, it's a lot of wisdom. It just takes a lot of wisdom to kind of think about it and to weigh it. So I'm going to ask a favor. So anyone who's asking these questions, I'm actually not looking at the questions directly. So do me a favor, hold on to your question, save it, and then when we're all done, ask it again, and I'll answer it at the end, just so I don't forget. Okay, next question. Any experience with dragon's blood for diarrhea? Well, I was watching Game of Thrones the other day, and it seemed to cause more diarrhea if you drank dragon blood. I don't know. I don't know. Well, I mean, dragons are a big Chinese thing, so maybe. We're Googling as we speak. We'll do the next one. We'll come back to it. Can a primary non-functional tumor metastasize and create functional tumors? The primary is pancreatic. So the answer is yes, maybe. So the question really is, if it's already metastasized. Okay, so I'm guessing, I don't know the scenario, but I'm guessing the scenario is basically you had a tumor in your pancreas, it was non-functional, you had it removed, and then it's metastasized, and now you have symptoms. I hope that's correct, whoever asked that question. If that is the situation, then that is possible, but also unclear, because generally the primary tumors of the pancreas tend to be in the head of the pancreas, generally, not perfect, but generally. The ones in the tail tend to be a little bit more asymptomatic. or at least non-hormonal, non-functional. And when they spread, they certainly can cause things. But the problem is once you've had that surgery, things have changed. So, so the answer is yes, always. Things can change. And we have one person on here, I think she's on here, in which her tumors started to change and started to secrete cortisol. Right? She had a small bowel neuroendocrine that started to secrete cortisol. I've never seen all puffy and stuff like that, and we had to get that all fixed, and she's better now. But the answer is yes. Anything can happen, and you've got to figure it out. Okay, dragon's blood. It's a red plant resin. I don't even know what a dragon tree is.
I don't either.
Perhaps I should plant a dragon tree and see what happens. I don't know. I can't answer the dragon tree thing. Sorry, gang. We'll have to, if anyone knows anything about it, teach us about it. Next question. What is the best way to differentiate between bone mets in general on a PET dotatate scan, specifically spinal and the presence of degenerative disc disease? Yes, so I can actually answer that question. So on a dotatate PET CT, the difference is this. Neuroendocrine tumors tend to be extremely, extremely bright. So when you look at a scan, so this is how octreotide scans are different from PET scans. It's the degree, you can actually quantitate how bright it is. And what that means is how much receptor it is. So when people have degenerative disc disease, arthritis of the back and stuff like injuries and stuff like that, they will usually have uptake of the dotatate because the dotatate goes to the inflammation because it binds to white blood cells. So it goes to inflammation and some of the blood vessels as well too. And then what happens is it glows, but it's very, very dim. It's very dim. So the SUV, which is kind of the brightness scale, maybe like 4 or 5 or 6. Whereas generally, and again, this is all very general, neuroendocrine tumors tend to be like 15, 20, 25-ish, something in that range. So again, the devil's in the details, and it depends on how much uptake the primary tumors have, how they look and stuff like that. But that's generally how we determine the difference, and shape. So degenerative disc disease tends to be a little bit more what we call diffuse, kind of a little spread out, a little bit more amorphous kind of a shape. Whereas generally, again, not 100% true, neuroendocrine tumors look like this. They look like a ball. And so when they look like a ball, that's usually a tumor. And when they're not a ball, they're usually inflammation. But again, very general. We'll see. Next question. Vanna. Am I dating myself that I even know who Vanna White is?
No,
Does she still work?
She's still on the show.
Is she really? That's amazing. Gosh. I think I remember when Vanna White started. You guys remember when Vanna White started working in that? Yeah, I guess maybe I did date myself. I was a kid. My grandparents loved to watch Wheel of Fortune. Well, they didn't speak
It's a good
English.
show.
Yeah, and so those are the where they were learned words.
So cool. No.
Sorry, Vanna.
No worries, man.
Yeah, is meningioma that lights up on PET dotatate considered a net? If so, how would that be treated? The answer is no. It is not a net. So just to back up a little, so meningiomas are tiny little, generally benign tumors of the lining of your brain and your central nervous system. So your brain down into your spine. And they're just little growths, basically. See, Penny Lee wants to buy a vowel. I like that. It's always a good strategy. Always a good strategy. So they're little growths, and for whatever reason, they light up very, very, very bright with somatostatin receptor. So you have to know what's going on. You have to know where the position is, and you have to know that to expect these things. And this is the problem, right? If you don't have the right expertise, people will like think that it's a tumor, and then you go down a rabbit hole and it's like, oh my gosh, and you're like, it drives me nuts. In general, meningiomas are very, 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 very benign. They can grow a tiny, tiny little bit, but they're very, very stable usually, and usually people are asymptomatic of it. When they grow, there's actually a problem. So you can have a meningioma that can be a tumor as well, and it happens to be picked up, and you happen to have both. But in general, the answer is no. The meningiomas are generally benign. Next slide. Can gallium-68 and copper-64 light up due to previous or current traumatic injury to bone and surrounding soft tissue? So this is very similar to the last question. So the answer is yes. The answer is yes. But again, they tend to look different. They tend to have different shapes. They tend to have different distribution. They have different brightnesses. Sweet. Good question. But an important question. Yeah. You know, a lot of the radiologists don't know that. Yeah. Are there any dental issues or concerns with regular monthly lanreotide injections? Not that I know of. Yeah, maybe blood sugar. Yeah, Kate was like maybe blood sugar, but not really. Most people don't become frankly diabetic, like overtly diabetic with the shot.
No mouth sores.
No mouth sores.
Yeah.
The drugs some of the drugs cause mouth sores.
Dentation.
No, nothing I can think of. Go ahead, next slide. Any correlation? Oh, here we go. Any correlation between lanreotide and low ACTH levels? The answer is yes. So, but it's usually not that bad. So lanreotide and octreotide, they're both what are called somatostatin analogs. And the goal of somatostatin is to depress the hormones. And one of the places it works very profoundly is the pituitary, which is where a hormone called ACTH is produced. ACTH is a hormone. It's a small hormone that goes to your essentially goes down to your adrenal glands, and then tells them to make more cortisol, some more steroid to kind of boost you up. But it can be suppressive. And so that's the purpose of the drug. So when people have some fatigue or they have some issues and stuff like that, you have to wonder if they're having some of these, some cortisol suppression. And you have to think about that. It's usually actually very well tolerated. Most people don't have anything terrible, but it certainly can be, and it can muck with your levels. Thyroid is another good one. Sugars, as we mentioned, is another one that we will kind of frequently see. So the answer is yes. Next slide. When tumors previously classified as well differentiated or reclassified as ill-defined, is that ill-defined?
Yeah.
Ill-defined. Should a biopsy be performed to determine gradient changes, especially in cases of chromogram increase? Okay. So in general, I don't do that. So I will tell you. So basically, I think the question is asking, okay, yeah, it's good, yeah. So you had it removed or you had a biopsy and it was considered well defined. So not well differentiated. Well differentiated. Yeah, maybe it's well differentiated. Yeah. So maybe we'll differentiate it and then reclassified as ill-defined.
How is it reclassified?
Yeah. I don't.
Yeah.
I may not be able to answer that question because I'm not sure what the question's actually asking. So we don't use the word well-defined or ill-defined. Well-defined and ill-defined means something to me because it means it's round, it's well-shaped, like I can get my fingers around it. Basically, that's how I think of it. But if it's well-differentiated between poorly differentiated or high grade, that's a kind of a different story. So yeah, so a biopsy is very reasonable if they want to look at it. Biopsies tend to be inaccurate. That's the real problem.
Doesn't that require a biopsy to change?
Yeah, good point. Yeah, good point. I don't know. I'm not sure how to answer that question. You may have to rephrase the question and ask again if you're on today. Go ahead, Marga.
This one you can answer.
Ah, yes. Can you give an update on the application of histotripsy? So, just to back up in case anyone hasn't heard, which I don't think any of you have not heard, but histotripsy is a machine that is now out and produced, in which you can shine ultrasound beams into a tumor into the liver without making any incisions, and the sound beams help destroy the tumor. It was tested and approved by the FDA a couple of years ago. We got a machine. I did a whole bunch of them. And it seems to be actually more effective for other types of tumors. So like liver tumors, what we call hepatocellular carcinoma, maybe certain metastases of other kinds of cancer like colon cancer. But in my experience, and I'm not perfect by any means, but I've done this like 70 times now. And I keep trying and just kind of tinkering, just not at the same rate I used to. It doesn't seem to work very well. It doesn't seem to be very strong. And so I've been tinkering with it. And then when I tinker with it to make it stronger, it's more toxic to the patient. So it's not perfect. It's not perfect. I have by no means figured out how to do it. And I think the problem is physics. I don't think it's actually me. And I'm not even sure it's really the machine. I think it's just the physics of the sound beams and the nature and the texture of the tumors. They're not that compatible. So I feel I get a lot more done. So if you have liver cancer, yes, I think it's a very reasonable option. But for neuroendocrine, it just doesn't seem to work that well. And so I've kind of backed off a little bit on doing it because just for that reason. It's still a good, wonderful technology and technique, and I think it needs to be worked out. it's not as exciting for me and for us as I had hoped it would be. Yeah. So, next question. Can long-term survivors on monthly octreotide or lanreotide treatment ever wean off medication? How would you know when it's time to stop treatment? That is an interesting question, and that's actually a very difficult question to answer. I've done this a few times before just to kind of figure out what happens, and sometimes it works and sometimes it does not. Here's the answer to the question. If you didn't need the shot in the first place, then you can take a break. If you needed the shot from the very beginning and it works for you, you're stuck on it. Okay, so what does that mean? So let me back up a little bit. So, the shot is a hormone, it's a suppressive hormone. Let me just tell you what happens in real life, and then you guys can think about it. But basically what happens in real life is you get diagnosed, your oncologist doesn't know anything about the disease. They open the book and they say, okay, start with treatment. And they just hit you with treatment. And they just start you, whether you actually really, really need it or not. And then what can you do? You can't stop. No one will stop you because they're not sure whether you'll grow or not. So if you want to really know, you have to make sure you have enough runway, right? So your disease burden is small enough that if you stop it and it grows, you can tolerate it. And then you have to be willing to scan more frequently to find out, and you have to be willing to accept the fact that your tumors might grow without the shot. Okay. But we've had several people who I said, okay, let's not even start. Let me get you cleaned up. We'll take care of all these things and we'll see how you do. And I've had people on like 5, 10, 15 years who've been on nothing and their disease doesn't grow. So they didn't even need the shot to begin with. So this is the problem. But I've also had people who they really want to take a break. We took a 6-month break. I repeated the scan and the tumors grew. Now, of course, you just have to accept that fact. It is what it is. But you can do that. But you have to do it judiciously and cautiously. And I would talk to a real high-level net specialist if you really want to do that, because most people won't stop the drug because they don't want to rock the boat and they don't want to take the risk. So that's the issue. So that's the truth. What you choose to do with it is a little bit up to you. Yeah. Next question.
This one's a doozer.
Ooh. Do you have experience with whole genome sequencing and tumor organoid tests for grade 2 patients to assist in determining treatment and identifying mutations in the cancer cells? So we just talked about that today. So basically the question's asking this. If you take the tumor and you do a genetic sequencing of it, is it helpful? If you take the tumor and you grow it in a petri dish, essentially, does it help you figure out what to do? I can answer both those questions. The answer is generally no for both, generally. Not 100%, but generally. So I sent almost essentially all of my tumors off for genetic sequencing because I don't want to miss anything. It's not perfect, but the problem is most of the time I don't find anything. In fact, interestingly, neuroendocrine, it's true, we just did today. Yeah. Neuroendocrine tumors in general are very, very mutationally stable. They're very, very quiet, which is why it's, the way it is and why we have long, long conversations and I can know patients for decades. It's because they're not that angry, which is great, except when they are. And when they are, then the mutations are usually helpful, but then you usually find a lot of mutations. And so I can almost tell right away, just by looking at the patient, what I have a strong suspicion as to what their results are going to be. As far as the organoids go, I have not had any success with that. And there are two reasons. One is they don't grow very well as organoids. That's actually a big problem. And just for if you don't know, an organoid is basically a 3-dimensional structure. I don't know, people do it differently, but basically you take the cells, you take them from a tumor, you grow them inside a media for a little bit, and then you mix it with a thing, and then you grow it in suspension, and it kind of forms this 3-dimensional lattice. So the idea being it doesn't grow well on a plastic piece of dish, right, which I understand, but it grows in this sphere, in this kind of almost I don't think it's gelatin, but it's some kind of matrix. I'm sorry, I don't remember what the matrix is. I have sent dozens and dozens of these tumors to people and they don't grow very well. So if they do grow well, that's actually a problem. But I usually know that because it's usually growing in the person, right? And so I usually know. So the value of those things is very, I would say moderate, because for me it's actually quite low. But if you want to give it a go, if we can learn something from it, or you're the one person that works for it, I'm totally okay with that.
That's the end of the question.
Oh my gosh, look at us.
Ah,
We crushed that. Half an hour, 17 questions.
Yep.
All right, friends. Boy, throwing me all these easy questions. Dang, what's going on with you? Why don't you people challenge me a little bit? I mean, what's going on here? Oh, I know, exactly. Yeah, but I can't do I won't know the puzzle for the Wheel of Fortune. Okay, all right, friends, since we are all done, why don't you go ahead and start asking. Okay, so Joanna, she says, my mom has had wow, that's things. 3 primary cancers: renal cell carcinoma, neuroendocrine in her lung, and ocular melanoma. Wow. In June, she's had metastases to the bones. Doctors were trying to determine which cancer has spread. They did a dotatate scan and it lit up. However, it looked mild. Is there such a thing as intensity of how the things change? Yes, yes, yes. Oh, yes. That's a good question, Joanna. And I think I kind of addressed it. So in general, strong neuroendocrine tumors do tend to light up. The problem is lung. Lung is very inconsistent. So if you really want to know, you better stick a needle into it and figure it out. Because if she has metastatic ocular melanoma, that is miserable. Especially if it's in her liver already, because that's the usual place where ocular melanoma goes. It goes to I think, as I recall, it goes mostly to the liver and also to the bowel. It's a very weird place for it to go. But ocular melanoma is a very, very weird disease. Yeah, it's a very weird disease. How do you find, oh, here's a good one. How do you find a real good NETS oncologist? My husband goes to the Ohio State University. Wait, did Ohio State win the national championship this year? Oh, sorry, Ohio people. Sorry about that. It was just, I just couldn't resist. My husband goes to Ohio State, and I feel like they are so clueless. I learned more from reading and listening to you than the doctors at OSU. They said my husband was grade 1, stage 3 in 2024, removed tumors in the small intestine, lymph nodes, but it returned in less than a year and is now in the spine. We asked how was it grade 1 if it grew so fast. They said, I don't know. We will take it to the board. Take it to the board. That's like everyone's answer. So
you don't know.
Cop out. Still no answer or a clue. So frustrating. Okay, well, let me answer that for you as best I can, Margaret. Again, not having studied your husband's case, I cannot give you any details. So total disclaimer. But the truth of the matter is, in general, people don't see it. People don't look carefully enough, and it's actually there at the very, very beginning. So if you have metastatic small bowel neuroendocrine tumor, it can go anywhere. But don't fool yourself. You've had the disease probably for years, or your husband has had the disease for years. So to think that all of a sudden taking it out is going to, eliminate all your problems it's just not true. It's just not true. And so it's one thing to remove it because your stomach hurts all the time. Yes, that is important. That is super important. But I tell people all the time, look, I know it's disappointing, but when it shows up in your liver and when it shows up in your bone, we'll deal with it, right? And it's not necessarily that it showed up so fast. It was probably always there, and you just happen to have found it now, right? And so this is kind of like what we were talking about that case before with the scan. And I had this problem because there were no dotatate scans before I developed it. And when I started developing it, I was like, oh my gosh, look at all the stuff I see. It was so bad that no one believed me. No one believed me. They're like, oh yeah, that scan's not accurate.
Not good.
I'm like, are you crazy? Yeah. And now so anyway, I get the experience. I'm sorry about your frustrations, Margaret. I don't know how to answer your question. There are a lot of people who really, really specialize in neuroendocrine. And there are a lot of people who claim to specialize in neuroendocrine. And then there are centers that say they specialize in neuroendocrine. So I don't have a great answer for you. What I will tell you is that the Healing Net Foundation is going to work very hard on try to develop a real true fellowship program. So just as you would see an endocrinologist or a breast surgeon or a colorectal surgeon, we're going to try to do that for neuroendocrine. I don't know if we can or not. I really think we need to, but we need your support. All of you people need to support us because it's so very important. And that's the issue. Oh, look at Jim. How about those Patriots? Guess who's coming to town next week? Guess who's coming to town? And possibly going to Super Bowl. The Patriots. Hey, it would be a rematch. Patriots versus Seahawks, possibly. Yeah, that would be actually pretty exciting. Ken's here. Ken is always here. Ken and Cindy are always here hanging out with me. Always, always, always. Let's see. Marion says, my last scan showed this. Should I be concerned? I have neuroendocrine tumors in both of my lungs. Monitor in both of my lungs monitor. 22. Now it also shows liver cells. Right. Marion, I don't understand your question. You may have to rephrase it and ask me again. I don't know if it shows liver cells by carcinoma. Rephrase it and ask me again. Christine, what are your thoughts about taking everolimus for a 4.8 by 3.9 medial border portal vein versus SBRT? So Christine, is that a, you'll have to answer for me, is that a, and I really can't answer it to be totally honest, but is that a tumor inside your portal vein or is that a tumor that's around your portal vein? Because I would just remove it. I mean, that's what I would do. I mean, you can do whatever you want, but that's what I would do. Lisa, Lisa, give us a call. Tell us how things went. Would you do that for me? Yeah. Adding on to an earlier question, if octreotide caused pancreatic insufficiency, will the pancreas become sufficient again if octreotide stop? Yes, possibly. Yes, possibly. No guarantee, but yes, possibly. But give us a call tomorrow and let us know how the procedures went for you. Mimi, if after having been on lanreotide for 2 years, hot flashes start again, should a bi-weekly regimen of lanreotide be considered? It's not unreasonable. You could certainly try 3 weeks first and just kind of see how that goes. And the other thing that you could try too, you could try the baby little rescue octreotide shots. Sometimes those can be pretty good for symptoms. And always the most important thing is to treat the cancer. Treat the cancer. That's always the most important thing. Okay. Natasha says, NED for 10 years. Congratulations. Net love to 40-year-old heavy period. Can I take progesterone? I don't know specifically for you, Natasha. It's hard for me to recommendation, but it is not unreasonable to try some of these medications to help, as long as it's still very low dose. You always want to start low and work your way up. And especially since you've been out for 10 years, that's probably good news. But you really want to talk to your doc about it. Oh, Joanna, my mom is being treated in Poland. Very few net specialists there. Is it possible to consultation? Sure. So the answer, Joanna, is yes. So if you can just call my office or email our office, you can here. I'll put Alex's email address here. Alex is my assistant, and she helps with all the new patients coming. And we see patients all the time from far away. You just have to help us get the records. That's the hardest part, because if it's in Polish, I can't read it, obviously. But the pictures I can certainly look at and help you. And we just do it over Zoom. Jan says, I'm taking lanreotide every 21 days because my liver tumors were growing. Is there a good optic before, a good option before other treatments? Well, I don't know the answer to that, Jan, because it depends on how big they are, how fast they're growing, all those things. I think everyone 21 days is reasonable. There are other meds you can try. There's always surgery. There's liver-directed therapy. All those things are very, very, they're tools in the toolbox, put it that way. It just, I can't tell you how to choose them depending on what the situation is. See, Kathy says, that was funny. Kathy thinks I'm funny.
Kathy thinks you're funny and handsome.
Thank you. Thank you. Steve says, with 6-month follow-up scans showing about 1 million growth each time, Dr. considers disease stable. At what point does the sum of the small growths being considered no longer stable? Is the total size of tumor? So that's hard, Steve. If it grows by just 1 millimeter here and there, the problem is it has to do with the insensitivity and the not insensitivity, the imprecision of the scan. So if it's a little here and there, it's fine. But if you really want to know, then just go back farther in time. So if you've been doing this for 3 years, go back to the one 3 years ago and look at the one today and see how much it's changed. If it's only changed like up and down a little bit by 1 or 2 or 3 millimeters, then you're in pretty good shape. Naomi, welcome. Hope you're feeling better. Sherry, questions. Are there any concerns using epinephrine when freezing for dental work? Oh, I see. Can it trigger hormone release? The answer is no. If you need epinephrine because it's safer for you, here's what usually happens with people who have epinephrine and neuroendocrine. Their heart rate goes up a little bit. Yeah, their blood pressure will go up a little bit. They may feel a little anxious. Let me tell you what happens when you give me epinephrine. My heart rate goes up a little bit. My blood pressure definitely goes up, and I get a little anxious. Yeah. So that's what epinephrine does. That's what it does. No one has an allergy to epinephrine. In fact, it's caused a lot of problem in our neuroendocrine world. So yes, you might feel a little funky with it, but it's okay. I'd rather you do that than bleed. That's how I feel. Yeah. All right, Annie from Oklahoma. We just gained a pharmacist from RMCC. Oh, Rachel. Oh, is that Rachel Tooker? Annie? I didn't know she moved to Oklahoma. Oh. Hi, Rachel. Tell her we miss her. Well, tell her I miss her. I didn't know she was gone. Gwen, I asked the. Oh, here, Gwen. Okay, good. Yeah. Okay, here. Let me see what you said here, Gwen. Hold on. Let me read this. I was under the impression the radiologist meant poorly differentiate. Actually, the description of the PET indicating the liver tumor is now ill-defined meant the tumor was blending with normal tissue and lines were not clear. Okay, so that actually is what ill-defined means. So Gwen, by the way, I have Gwen's book here on my bookshelf. Yeah, it's somewhere inside there. Gwen wrote a book about her whole journey and stuff like that. The answer to the question is it depends on the scan. So if it is on the PET scan and it's not so clear, it's because it glows. So that's the wrong test to use to look for you, Gwen, right? So if you really want to know if it's well-defined or not, then you need to do a clean MRI or a very, very clean CT scan to figure that out. Because those are the more, what we call, what's that?
The precision.
It is the precision, but really it's about like cross-sectional imaging is not functional imaging, so it doesn't glow, right? It distorts it because of the glow. Okay, Jim, let's see here. Had net tumor removed 5 years ago. Been no evidence since then. Just got to. Oh, Jim, I'm so sorry. Could this be related? Thank you for being you. Jim, probably not. The problem is that the longer we keep you alive with neuroendocrine, the more chance you'll have of getting something else, which is why you still have to have colonoscopies and you still have to have mammograms and all the other tests and diabetes and things, hypertension. They still happen. The problem is that there's more and more neuroendocrine. That's the problem. And neuroendocrine does not protect you from anything else. So yes, the answer, unfortunately, is that they're not related, but yes, people are going to get more things. Johnny says, do certain net mets have better prognosis versus the others? Are bone mets harder to treat comparing to, say, liver mets? So Johnny, the answer is yes and no, kind of. So the bone mets for like prostate cancer, and we just talked prostate cancer, and other kinds of cancer are brutal because they cause a lot of pain and can cause fractures. Neuroendocrine is a little bit more forgiving generally with their bone mets generally. And generally, no one dies of bone mets until they're really pretty bad. So the prognosis is worse than not having bone mets, of course, but it's not terrible. It's manageable. So Sheena says, okay, I have a huge question. I am not diabetic. Half my pancreas is gone. I'm not diabetic with, I assume, a hemoglobin A1C of 6.7. What is the best diabetic medicine or shots that won't cause neuroendocrine to grow again? I've had 2 primaries now, but negative for MEN. Well, that's fascinating. 2 primaries. I think I kind of answered before, Sheena. I like insulin, especially if you're missing half your pancreas, because basically you're insulin deficient. That's the problem. But there are other kinds of treatments, and maybe you can get away with it because you don't want shots. But insulin, for me, is the best, most physiologic, most effective, most natural, actually, kind of therapy that you can get. All right, Susie, getting a new brain scan in a week, plus hoping CyberKnife did its job. Yes, that would be great, Susie. And I'm done with brain bleeds. Has affected my taste and smell. Did I realize? Yes, it is true. Yeah, zapping any part of your body with radiation is not great. Jared wishes he was coming sooner to see the Patriots versus the Broncos. That would be good, but you'd also have to bring $1,000 for a ticket to go watch. Yeah, exactly. So we can watch from the bar. Margaret, thank you. I wish we had a list of those good approved doctors. Yes, well, let me say one more thing about the doctors, though, is that even if they're a really great and experienced doctor, we can still disagree. we can still disagree. Because the problem is if you see 7 really good neuroendocrine doctors, you might get 7 different opinions. Either you'll get 1 opinion or 7 opinions. And that's where it becomes quite a challenge, right? I feel very strongly that I'm right.
Yeah.
I do.
Yeah.
But it doesn't mean that there aren't other ways of doing things, right? And so maybe not today. Maybe try this. Try that. It's like, yeah, that's not a bad idea. If someone has a good idea, I usually try to copy it. That's usually what I do. I try to incorporate it. Yeah. But that's just me. Gloria, which is better for monitoring net in the pericardium? Oh yeah. Gloria has a really interesting one. You know, I think basically the echo is good enough just to see that the function is good. But in general, the cardiac MRI is definitely, it's more expensive and more technically difficult, but is better for looking at it. And that's what I would do for you, Gloria. But I mean, Gloria, you're so well. Gloria's like living life. Tell us, Gloria, how you're living life and enjoying things. You know, that's the most important thing, period. Christine, what are your thoughts? Oh yeah, we talked about this. Yeah, you have to tell me what that means, Christine. Marion, I have had net in both lungs. Last scan showed liver carcinoma that I had been told we will watch. I've been on therapy for 3 years now. That's a little odd, Marion. So if you have liver carcinoma, something is wrong because carcinoma is bad. That's like bad cancer. So I cannot make any comments on it because I don't understand it. So strange. I don't know. Ah, Robin's here. All right, we'll see you soon, Robin. All right, see here. Ah, okay. It is Rachel Tucker. Camille asks, I have had a Whipple, PRT, and 8 years of lanreotide. Is there a treatment on the lanreotide injections that could be used to keep the peanut secondary liver cancer stable? Yes, there certainly are. If you don't like the shot, Camille, the problem is you're starting to trade off the shot and its very mildness for side effects. So if you start to take pills like everolimus or cabozantinib or sunitinib, they just have more side effects, but they're pills. So those are options. You could also do embolizations and stuff like that. It depends on how much you have, how dangerous it is, how much it's secreting, like all the things. So we have to, all those things really come into play. Jody asks, how long does Cabo usually provide stability grade 2 KS13? Probably about a year, roughly. Jason says, any info on H2 blockers for symptoms? Yeah, for sure. I mean, if you want to try some Pepcid or something like that, definitely. I think it's definitely very reasonable. Or Benadryl. The only problem is it makes you sleepy, right? I mean, the H1 blockers make you sleepy, but if you want to try some Pepcid or Zantac or that kind of yeah, that's Zyrtec. That's all very reasonable. All right, welcome, Louise. Welcome. Let's see here. Matisa says, why aren't your pet dotates done normally from Vertex when most order from Skullbase? Yeah, because they do it wrong, Matisa. That's how I feel about it. So let me answer this question real quick. So Matisa asks a very sophisticated question. In general, when you order an FDG PET scan, which is the classic PET scan that we do it's a sugar scan for kind of regular cancers, they order what's called base of skull to mid-thigh. And the reason they do that is because the brain eats up a ton of sugar. So you don't get any information. But if you do a dotatate scan, you kind of want to look up here because you can have metastases inside your skull. It may not make a huge difference, but it helps. I mean, I think you want to know, right? I think it's important. So I always order Vertex, which is here, the Vertex, to mid-thigh, so I can look at your whole thigh. When people don't order that, I think they don't know the difference. It may not make a difference. Honestly, it may not matter, but I think that's the major reason. Just had to deal with a collapse. Oh, sorry, Kathy. Yikes. From nets compression on the bronchial tubes. Yes, that does happen. And that is a big problem. And it's complicated. Yes, Gloria, life is awesome. That is so fantastic. Oh, Carolyn is here. Carolyn, remind me, Carolyn, call me because I need to connect you with Lev. But as you all know, Carolyn is the program director of the HealingNet Foundation, and we're working very, very, very hard on our summit this year to talk about this fellowship program, to answer just some of these questions that have been answered here or asked here. Wendy Knoll, my favorite veterinarian. Wendy Knoll, let me tell you something. I am feeding my dog natural foods now, so that's it. I'm not listening to you anymore. Okay. Hey, just made it 20 years with Nets. Wanted to say thank you for being a part of it. Love you lots. Mwah. Love you too. Congratulations. And my dog, who loves her food better. Joanna, I just want to say thank you for what you're doing for. Oh, it is my My pleasure. Yeah, so of course your job is always to reinforce me because I have a very, very small ego and very delicate. So I need you to tell me that this is worth doing and that's helpful to you, and I will keep doing it. So Tim, I buried my head in the sand for a long time, almost 6 years. When it's time to get some checkup scans, still experiencing the flushing and arch of bowel flows. Tim, I'm here, dude. I mean, just you make an appointment and just come on up, and we'll start figuring stuff out again. All right. I mean, I've known you for a long time, Tim. So just feel free to just come on. You always got to catch up. Oh, look at Leslie, also 20 years this month. It's amazing. Um, Elena's here. I'm at 16 years. It's amazing. Ken, see you on Tuesday. Go Broncos. I know. Fingers crossed. All right, friends. I guess that's it. Thanks for joining. Again, we'll see you next month. And I really, really need you guys to go to the Healing Net Foundation and donate some money and donate some of your time and be a part of it and spread the word and do all the things, because we're trying to do some big things now. I think it's time. I think neuroendocrine has been in the shadows long enough, and it's time for it to really, really get the attention that it deserves. And so, if the Healing Net Foundation can produce a real fellowship, so we can produce real specialists in the future, I think that would radically change the way that we care for you guys. We literally had today multiple cases of people who were just, it was almost cruel how they were treated. Yeah, it was almost cruel. And it's wrong, and we need to do something about it. And I'm not getting any younger. Eleanor's getting younger, but I'm not getting any younger. And so if we don't do this now, it'll never happen. So support me, support us, support each other, support our community, and just know that we will do everything to help take care of you. All right, you guys be well, be healthy. See ya. Bye, guys.